Good evening, everyone. My name is Truls Bjørklund Johansen. I am Emeritus Professor of Urology at the University of Oslo, Norway, and the University of Aarhus in Denmark. And it is a pleasure to welcome you to this ESIU webinar on antimicrobial resistance, antimicrobial stewardship, and the O Neill report. You may have heard that the Dow Jones has been going down during the day, but the number of registrations for this webinar has been going up, and we are now at 207 registrations. Like the other faculty members, I have a deep interest in this topic, but I am convinced that none of us has any conflicts related to this topic. And I would like to thank the European School of Urology and Zafer Tandogdu, who is chair of the ESIU, for inviting me to chair this webinar together with my co-chair, Jenny Kranz. Jenny is head of the Department of Urology and Pediatric Urology at the University Hospital in Aachen, Germany, and she is co-chair of the EAU Guidelines Panel on Infections. So I am proud and honored to introduce our first presenter, who is Søren Schubert. He is a clinical microbiologist, professor of medical microbiology at the University of Munich, and a member of the EAU Guidelines Panel on Urological Infections. And the topic of his lecture is to teach us what the urologist should know about antimicrobial resistance. So please, Søren.
Yes, ladies and gentlemen, good evening. Truls, thank you very much for the kind introduction. It is a pleasure for me to present you tonight a short presentation on antimicrobial resistance. And I have no potential conflict of interest to report. So as mentioned, the title of my presentation is What the Urologists Need to Know About Antimicrobial Resistance, AMR. I would like to start a little different. I would like to ask why the urologists need to know about antimicrobial resistance. And the answer to this question is very simple, because looking at this slide, you see the global burden of antimicrobial resistance, and that bacterial antimicrobial resistance indeed is a global threat. Here are data of 2019 showing that the world map, the heat map, and you see that there are a couple of countries, India and Southeast Asia, where you have a prevalence of third-generation cephalosporin resistant E. coli up to 80%. But even if you look at Europe and Germany, we had at that time resistance rates up to 20%. And things look even worse in the future, at least according to a publication in The Lancet recently. The authors claim or forecast that there will be an increase of the annual death associated with AMR, climbing from 4.7 million in 2021 up to 8.2 million deaths per year in 2050. So there is an increase of about 75%. Well, but let's first look at the principles of AMR. And you can see that, you know that bacteria have developed different strategies to survive in the presence of antibiotics. They could, for example, exploit or develop efflux pumps to get rid of antibiotics from the inside of the bacteria and to pump it outside. On the other hand, they can also decrease the uptake in terms that they close tunnel proteins, porins, so that the antibiotics cannot reach the inner part of the bacteria. They are further able to modify target structures, for example, by point mutation of the ribosomal RNA, in order to avoid the binding and the action of the antibiotic to the target site. This is true, for example, for macrolide resistance. And it's also true for modification of the enzymes like uases and topomerases, isomerases, which leads to a resistance against cephalosporins and ciprofloxacin, for example, in uases. And on the other hand, the bacteria can develop or produce alternative enzymes to circumvent blocked pathways by the antibiotic. This is true for trimethoprim sulfamethoxazole, and this also leads to resistance. So while these mechanisms here usually lead only to a low or moderate resistance, the contrast here, the presence of inactivating enzymes lead to are associated with a high levels of resistance and a great clinical significance. The beta-lactamases here, the beta-lactam antibiotics. And the single mutants lead to quinolone resistance, macrolide resistance, and efflux pump activation. And these single mutants can develop during this therapy with antibiotics. However, this is a very rare event. Much more of importance are the resistance mechanisms where resistance genes like the beta-lactamases are selected during the antibiotic treatment. So there are pre-existing antimicrobial resistant bugs or genes which are on the surface of the mucosa, like in the gut or in the respiratory tract, and they were selected during the treatment. So the driving force of AMR is indeed the antibiotic usage, and that can take place, of course, in the human healthcare setting, so in the hospital, or of course also in the outpatient setting, but also antibiotic usage in animal factories, in animal breedings, or also in the food factories there, leads to an increase of the selection here of these antibiotic bacteria in the gut of these animals. And those, by the food, these resistant bacteria enter the human body, so they are spread along the food chain, and also enter the environmental, and in this case, there is a circle which really leads by time to the enrichment of antibiotic resistance. But on the other hand, there is also a genetic transfer of antibiotic resistant determinants by different methods, like by phages or by the uptake of these naked DNA here from one bacteria to the other. The resistance can be transferred. But the most powerful system are these plasmids here, the circular plasmids, which can be easily transferred from one bacteria to the other in the gut of the patient, so that the resistance can be spread in the patient you treat with an antibiotic. This is something like you're using an external hard disk to your computer or USB stick, where you transfer lots of data which you can immediately access to. So, but let's have a look to the lab and how we identify the antimicrobial resistance. And usually we do it this way. We have this micro-dilution. So we dilute an antibiotic in a serial dilution like this here, from high concentration to low concentration. And we add different isolates, for example, of E. coli. And in the higher concentration, we have no growth. In the lower concentration, we do have growth. And an important point is the lowest concentration of the antibiotic, which leads to a no growth situation, which inhibits the growth. And this is the minimal inhibitory concentration, or MIC. And this MIC is a very important value to estimate whether the bacteria is resistant or susceptible to the specific bug. But to say this, we need another value, the clinical breakpoint. And this clinical breakpoint tells you if your MIC value is below this clinical breakpoint, this isolate is susceptible. As soon as the MIC value is above the clinical breakpoint, this isolate is resistant. The clinical breakpoint is given by different data, for example, pharmacological data like pharmacokinetic, pharmacodynamic data. but also data from animal models, animal experiments, but also, of course, from clinical studies and from human clinical data. So, we obtain this clinical breakpoint, the information in Europe, mainly by the UCAS, an organization, the European Committee on Antimicrobial Susceptibility Testing. It's a non-industry driven open access system or organization where the information are based on studies and rational models. In the US, you have the CLSI, which is a clinical and laboratory standard institute, which provides you also with comparable data and breakpoints. So simply speaking, you end up with a susceptible phenotype or resistant phenotype, but in some occasions you see on your report, on a resistant report, an I. So, but please don't worry about the I. The I means that the isolate is still susceptible. However, you need an increased exposure to have a success in this treatment of this bug. You have the definition means that, of course, susceptible means indeed you have a high likelihood of therapeutic success using a standard dosing regimen of the agent. The E means you have still you have a high likelihood of therapeutic success. However, you have to have an increased exposure of the bug to the antibiotic by either adjusting the dosage regimen, so increasing the dosage, or to treat the bacteria on a site of infection where the concentration of the antibiotic is already very high. And this is true, for example, when you treat bacteria with a beta-lactam antibiotic, which are in the urine compartment. And last but not least, the resistant phenotype means that there's high likelihood of therapeutic failure, even when there is an increased exposure. And these ideas, and when you look, for example, on this on the treatment of a bug with antibiotics here, you see that claiming you have a patient with a systemic urinary tract infection or with a urosepsis, and you treat them with IV antibiotics, with the beta-lactam antibiotics, and you measure the level of the concentration over time in the plasma of the patient, you end up with a curve like that. Here, a peak and then a decrease over time. When you plot now the MIC value into this here, this is the MIC, minimal inhibitory concentration of the bug, you see that there is a certain period of time where the level of the antibiotic in the blood is over above the MIC. And this time over MIC here is a critical term, a critical information, because this time correlates with the success of your antibiotic treatment. So the longer the time over MIC is, the more likely is a successful treatment of the critical infected patient. And so the idea is how to enlarge the time over MIC in order to gain a better outcome for the patient. And you can do that either by increasing the dosage here, like this here, then you gain time over MIC, or you could increase the time of application. So the peak of the level is less high. However, you stretch the curve and gain time over MIC. And this means that both increasing of the dosage, but also increasing of the time of application for beta-lactam antibiotics leads to a better and successful treatment. And these ideas, these two ideas, have entered now the brand new version, brand new edition of the EAU guideline on urological infection. And when you have a look at the tables there, table 5, for example, you see that there is standard dosages and high dosage. And in some instances, you see that the prolonged infusion is recommended in order to have a higher success in your treatment. Okay. When looking at the different levels of resistance for E. coli, for example, for beta-lactam antibiotics, you have the level 1. You see this is a wild type E. coli without any beta-lactamase. And you can see that all the beta-lactam antibiotics like penicillin, cephalosporins, and carbapenem will work well, and you have a susceptible phenotype in all. And you could treat this with ampicillin. Level 2 is the presence of a basic beta-lactamase in your E. coli, such as a TEM beta-lactamase, and you see that ampicillin and piperacillin will be destroyed by the TEM beta-lactamase. But as soon as you use a beta-lactamase inhibitor like sulbactam or tazobactam and all the other bacteria here, you will have a successful treatment. Level 3 is the presence of an extended spectrum beta-lactamase, and this kills not only the penicillins, but almost all the cephalosporins as well. So then you end up with a treatment of using carbapenems, for example, in case of a systemic infection. Then you end up with a meropenem, for example. But you have another fourth level, which is the presence of a carbapenemase. And this is maybe the worst case scenario, because then all the usually applied antibiotics of the beta-lactam groups are resistant. And you have to use a last resort antibiotic like ceftazidime, avibactam, or aztreonam, avibactam, and you're also it's wise to contact ID specialists to support the treatment of your patient. Well, another point you often face is the infection of urinary catheters. And as you know, that bacteria stick to the catheter and produce a biofilm like this light blue stuff here. And this extracellular matrix is a penetration barrier. And this is also kind of antimicrobial resistance, which is now due to the penetration barrier. And on the other hand, also the bacteria within this biofilm here, these bugs here, they modify and reduce the metabolism. So they try to sleep somehow. And this leads to a tolerance and persisting state of this bacteria. And on the other hand, the close proximity of these bacteria together leads to an increase of genetic exchange between these bacteria and also a spread of antimicrobial resistance determinants. So last not least, what about antimicrobial resistance and pathogenicity? It's worth to mention that antimicrobial bacteria are not necessarily more pathogenic. However, a delayed appropriate treatment leads to a worse outcome. And indeed, in some cases, AMR bacteria are less pathogenic due to the resistant mechanisms that lead to a reduction of fitness. That's, for example, true if they just block the tunnel protein, which are also necessary to take up nutrients, for example, for the bacteria. So to conclude my talk, I hope I could show you that indeed antimicrobial resistance, AMR, is a global threat. And AMR is fueled by antibiotic use both in human and in livestock. The selection of AMR bacteria is a relevant side effect in each and every antibiotic therapy. In case you face a patient with a systemic infection, it's wise to use MIC-guided therapy and think of the increased exposure and the prolongation of the infusion of beta-lactam antibiotics in order to improve the outcome of the patient. Please don't worry about an I in your antibiotic susceptibility report. This simply means it is susceptible. However, you have to increase the exposure. You have increased the dosage. And last not least, hygiene measures and rational use of antibiotics are important to prevent AMR. And the magic term is antibiotic stewardship. And you will, in the next talk, you will hear about antibiotic stewardship in the treatment and of urological patients. And with this, I would like to thank you for your attention, and I'm happy to answer your question. Thank you very much.
Thank you, Søren, for making all these complicated topics understandable for urologists. I thought I could ask you about this increasing resistance. Can you say anything about the risk of contamination? I mean, the risk for the urologist and his or her family of bringing these resistant bugs with him back from work to his family.
Mm-hmm. Yes, there is. First of all, there are no really valid data or thoroughly investigated studies addressing this topic. But indeed, there is a theoretical risk that by touching or getting in contact with a patient who carries these multi-drug resistant bacteria, that you will just colonize yourself and also spread this bacteria around your family or friends or whatever. However, the risk is rather low. Of course, you have, in case the patient has a highly resistant bacteria, you should use the hygiene measures in order to avoid transmission. That's one point. On the other hand, most of the bugs, especially the bugs important for urologists like E. coli, proteus, or others, these bugs are usually in the gut of the patient, and you have to have contact with not with the skin, because usually they're not colonized in the entire body, but the bug and the gut is one of the reservoirs of these multi-drug resistant bacteria. So there is a lower risk that you really get contaminated by these patients. On the other hand, when you pick up the bacteria, and that's usually a couple of them, they are not they will not really exchange a complete microbiome, but there will be only a tiny part of your microbiome. And as long as you and your family are not treated with antibiotics, these are one in a million of different species. So there's no really harm that you will be infected or ill. You are colonized perhaps, and but this is not sure how long you will be colonized. So to sum up, I personally feel that there is not really a high risk that you suffer from an infection of a multi-drug resistant when you contact your patient. In case you disinfect your hands and you follow the hygiene measures. That's my personal opinion.
Thank you, Søren. I believe Jenny will now introduce our next speaker.
Yeah, I also warmly welcome you to today's ESIU webinar, and it's an honor for me to introduce the next speaker. It's Professor Tommaso Cai. He's an associate professor of urology in the University of Trento in Italy, and he's the chairman of the urology unit in Santa Chiara Regional and Teaching Hospital in Trento as well. And moreover, he's a member of the EAU guideline panel of urological infections and a member of the ESIU. And the topic of his lecture for today's is antimicrobial stewardship. And you guys need to know that this is the topic of his Dr. Philos thesis. So as you can see, Professor Cai is a really expert in this field, and he has published numerous papers on this topic. And so, Tommaso, the stage is yours.
Thank you very much, Jenny, for this kind presentation. I share my video. So good afternoon, colleagues. Good afternoon, ladies and gentlemen, and many thanks to the EAU board for inviting me to speak about an important field in not only urological research, but also in everyday clinical practice, the role of antimicrobial stewardship in urology. So this is my disclosure statement, and this is my agenda for today. I would like to start from the definition of antimicrobial stewardship, and then I would like to discuss with you the update in urological clinical practice at the light of the O Neill report. This is very interesting report. Moreover, I would like also to discuss with you all areas in urological practice that is very important to take into account in order to improve our adherence to the principle of antimicrobial stewardship. And I would like to thank also to Søren to having introduced my topic. Starting from the definition, what does it mean, antimicrobial stewardship? Antimicrobial stewardship has been defined as a core set of action which promote the correct use of antibiotics in urology, of course, but not only because as we will see and discuss in my presentation, we will see that antimicrobial stewardship includes a lot of procedure that are very important to take into account in order to improve our adherence to antimicrobial stewardship. Moreover, antimicrobial stewardship is defined as a whole set of action to promote the correct use of antibiotic, because the correct use of antibiotics is very important in order to treat the infection, of course, but also in order to protect the patients and reduce the antimicrobial resistance. That is very important, as Soren has been demonstrated below. In other words, antimicrobial stewardship has three important pillars to consider. First of all, the improve of antibiotics efficacy, reduce antimicrobial resistance, protect the patients, and protect the environment in terms of reducing antimicrobial resistance. So, but a modern approach to urinary tract infection includes also several other aspects, such as a patient's engagement in terms of patient's education. This is very important to highlight, because several times patients use improperly antibiotic without physician consultation and without any prescription. This is very important. Engage the patients also in the antimicrobial stewardship. But what are the updates at the light of the O Neill reports? O Neill reports, as you will know, highlights several important aspects that we can take into account. The correct use of antibiotic, that is very important, but also we need to work a lot in order to have a new rapid, low-cost diagnostic test in order to perform a rapid diagnosis of urinary tract infection, for example, and reduce the use of antibiotic. Moreover, this is very important to take into account, especially in the era of antimicrobial resistance. Promote the use of an antimicrobial sparing approach, an alternative to antibiotic. Vaccine, for example, nutraceutical, in other treatment. But moreover, the O Neill report highlights the need for new drugs in order to overcome the problem of antimicrobial resistance. But this is very important, and the O Neill reports highlight and stress this aspect, that is very important to act locally in order to share the principle of antimicrobial stewardship among all healthcare professionals. Moving to the prescription of antibiotic and the core element of antimicrobial stewardship, we need to perform in everyday clinical practice a regular training of the staff, of our colleague, in order to promote the correct use of antibiotics. Moreover, we need to share the principle of in the indication of international guideline, and we need to increase the adherence to the local national guideline. Moreover, it's very important to perform a regular visit and audit with other specialists, microbiologists, for example. It's very important, and then infectious disease physicians. But it's very important also to take into account the local pathogen resistance profile. That is very important in order to find the correct antibiotic to use. But in everyday clinical practice, what are the areas in urological practice that we need to take into account? I would like to show you the American CDC program that highlights several aspects that are very important in order to increase our adherence to antimicrobial stewardship. And they set a lot of action both in outpatient and in inpatients. Starting from the outpatients, we need to consider the correct diagnostic approach to UTI, and we need also to take into account the indication of the international guideline, more important to the European Association for Urology guideline, in order to select the best antibiotic to use in the treatment of UTI. But also we need to consider the correct approach to the management of asymptomatic bacteriuria, and then perform a correct use of prophylaxis and management of recurrent UTI, in particular stress the importance of antimicrobial sparing approach and other non-antibiotic procedure, but it's a very important procedure to reduce resistance, perform a correct use of urinary catheter and nephrostomy, for example, and avoid the overuse of catheter. In our hospital, we have about 30% of overuse of catheter, and this is very important because this increases the risk of infection. This increase the risk of unnecessary antibiotic. The O Neill report stressed the need for accurate diagnosis. In particular, the O Neill report stressed the need for a rapid, low-cost diagnostic test for perform an accurate diagnosis of urinary tract infection, but unfortunately, up to the moment, we have no in everyday clinical practice a test to use with a rapid diagnosis and low cost. However, we need to consider the diagnostic approach to UTI. But coming back to the antibiotic choice, we need to consider several aspects before prescribe antibiotic, both in outpatient and in inpatients. We need to consider the spectrum of coverage, the patterns of resistance, as Soren before clearly highlighted. Moreover, we need to take into account the pharmacology of the antibiotics that I want to use. And moreover, we need to consider the correct dose and time of antibiotic. But also we need to take into account to treat the bacterial infection and not colonization. Several times we are guided to treat colonization, but not treat infection, because as we will discuss it before, many patients become colonized with the potential pathogenic bacteria, but they are not infected. This is only a colonization and not as infection. For instance, the management of asymptomatic bacteriuria or Foley catheter colonization is very important to take into account. Moreover, the presence of white blood cells in the urine is not indicative of infection, and the pyuria is not an indication to use antibiotic. Moreover, please consider that the fever may be due to another reason and not to the positive culture. Here, I would like to remember our study on asymptomatic bacteriuria management, in which we demonstrated that asymptomatic bacteriuria treatment is associated with another risk of new symptomatic episode and a high risk of resistant bacteria. Moreover, the role of chronic prostatitis, chronic pelvic pain symptom, all prostatitis without any bacterial identification. Also, in this case, we need to avoid to treat sterile infection, and we need to avoid use of antibiotic in this case of patients. For instance, we need to stop the use of antibiotics in order to decrease the level of PSA without any suspected of bacterial infection. Moving to another procedure that we need taking into account is the alternative approach to urinary tract infection. Here I reported the O Neill report, in which the O Neill stressed the role of antimicrobial stewardship, antimicrobial sparing approach to infectious disease. In urinary tract infection, we have tested a lot of nutraceutical, phytotherapy, and medical device that are able to decrease the risk of new episode and that is able to decrease the use of antibiotics. Here, for example, I reported the results of a systematic review and meta-analysis in which we demonstrate that medical devices containing xyloglucan, hibiscus, and propolis is able to reduce the symptomatic episode in a recurrent urinary tract infection and reduce the use of antibiotic, and then reduce the risk of antimicrobial resistance. But moving to the conclusion, what are the role of antimicrobial stewardship in urological impatients? So in urological impatients, we need to consider the role of antibiotic to urology, in particular in the prophylaxis, antimicrobial prophylaxis in all urological procedure. Moreover, we need to take into account the principle of antimicrobial stewardship in the management of complicated urinary tract infection and sepsis, and then the correct approach to urinary catheter. But it is very important, as my suggestion, to start to create an infection control team with microbiologists, with infectious disease, in order to share the principle of antimicrobial stewardship in all urological departments. For instance, here I reported the results from a study published several years ago, in which we demonstrated that the use of prophylaxis, antimicrobial prophylaxis in line with the recommendation of European Association of Urology guideline is able to reduce the use of antibiotic, the cost related to the antibiotic, and the risk of resistance. And this is very important to highlight in everyday clinical practice. But what about the antibiotic treatment for a complicated UTI and sepsis? We need to consider, of course, a collaboration with infectious disease, but we need also to consider that in 2 or 3 days we need to start a revision of the treatment if the patient's outcome is positive, and especially we need to start to the switch to oral therapy. But also we need to consider to do not give antibiotic with overlapping the activity, and this is very important. That is a very common mistake in everyday clinical practice. Moreover, we need to reduce the time of surgical prophylaxis until the 24 hours. And this is very important because in everyday clinical practice, several times I say that the antimicrobial prophylaxis continue for 1, 2, or 3 days after the procedure, and several times start 1 or 2 days before the procedure. We need also to consider the early removal of catheter, a pillar aspect of antimicrobial prophylaxis. And I would like to stress a concept that other preventive procedures such as hand hygiene and infection control practice are very strict to the principle of antimicrobial stewardship in urology. Moving to the conclusion, I would like to stress the importance of antimicrobial stewardship in all urological settings in order to increase our correct use of antibiotic and in order to reduce the risk of resistance, but because all urologists are called to increase their adherence to the principle of antimicrobial stewardship in everyday urological clinical practice. But looking to the future, I think that we need to start into thinking that the management of complicated urinary tract infection in hospital and sepsis, for example, is not only related to the use of antibiotic, the fluid supportive therapy, and the drainage of ashes, for example, but also is associated to a correct preventive approach to the resistance, because if I can reduce the resistance in my department, my urological department, I need to treat better my patients. In conclusion, I think that this is the time to change our road, and we need to increase our adherence to the European Association of Urology guideline in order to improve our adherence to the antimicrobial stewardship. So this is my last slide, and I would like to thank you for the attention.
Thank you for this excellent presentation, Tommaso. There is one question from the attendees. It is a colleague who would like to do a TURP on a carrier of multi-drug resistant pathogens. And the question is, can we, for example, postpone the TURP for 3 to 6 months and hope that the carriership will disappear? This is a practically important question. How would you answer this?
For my clinical point of view, I think that we can, TURP is a procedure for a benign disease, and I think that we can postpone the treatment of surgical treatment. But we can, it also depends from the patients if the patient have a catheter or not. This is a very important aspect to highlight. However, I would like also to ask to Søren what the microbiologists think about it.
Yeah, please, Søren, would you comment on that? Can we expect carriership of MDR to disappear after 6 months?
I think depends on bacteria located. So is it simply in the urinary tract, for example? Then it is possible to get rid of the bacteria, but as soon as the bacteria is in the gut, it is rather difficult or even impossible to get rid of the bacteria in a certain period of time, especially when the patient receives the antibiotic for other reasons in the future. Because if you have a patient who has other reasons to receive antibiotics, then there is a selection pressure in the gut, and that will prolong the carriage of the MDR drug-resistant bacteria. However, I agree to Tommaso that we should try at least to get rid of the bacteria, and we should give a shot on that. We give some time, and the reduction of the bacteria, at least on the surface of the urinary epithelial cell, would be perfect for this treatment. And another point is, if you know the target and the bacteria you're facing, then you could also, of course, make preventive measures and fine-tune your prophylaxis towards this specific resistant bacteria, and also the treatment after the TURP, in case you have any complication with which are probable infection.
Thank you, Søren. And our last speaker is Fabian Stangl. He is consultant urologist and senior fellow robotic surgeon in Hirslanden Clinic in Bern, Switzerland. He is a very active member of the Young Academic Urologist and the UTSolve research group, and also an associate member of the ESIU and the EAU guidelines panel. Because of family events, he could not be present today, so his presentation is pre-recorded, but you are, of course, still welcome to ask questions. So please, Fabian.
Thank you so much, Professor Berglund, for the kind invitation and the introduction to all this talk today. So my topic is, what will healthcare and urology look like in the coming decade if the O Neill report and predictions from the report come true? Regarding this talk, I do not have any conflict of interest. So the round was set very well by the faculty speaking before me regarding antimicrobial stewardship and antimicrobial resistance, and what urologists need to know, or better, what everybody needs to know. So the O Neill report was commissioned by the government of the United Kingdom in 2014 and published in 2016. The commission was led by an economist, Lord O Neill, who made quite dire predictions when it comes to antimicrobial resistance. They estimate that by 2050, we're talking about a global death toll of about 10 million people a year. And we as urologists are, or will, or already are affected highly by this issue. Urinary tract infections, diagnostic interventions with a high risk of infectious complications, stone surgeries, prostate biopsies, surgical site infections after major surgery, and this will have massive consequences for every urologist. What happens if these predictions come true? To make it more visual, we're talking about 10 million people by the year of 2050, a yearly death toll. At the moment, estimations would usually underestimate the deaths in underdeveloped countries are about 1.2 to 1.5 million a year. And by 2050, we will reach the same number as global cancer deaths per year. So to put this in perspective, we discuss cancer a lot on meetings, congresses, and cancer surgery is something I do in my daily practice. So it impacts us and me personally a lot, but an equal number of yearly mortality should give us a broader aspect, and we should increase our efforts to discuss this in a way deeper matter at our future meetings, for example. So what's at stake when discussing the O Neill report? As just said, 10 million deaths a year, an enormous economic loss of predictive 100 trillions worldwide speaking. So that's an enormous loss for every country on the planet. We will have fewer and fewer antibiotics that are effective in treating infections. Every high-risk medical procedure, high risk of infectious complications, is under threat. If we're discussing major surgery, cystectomy with orthophobic neobladder, for example, or PCNL and NL, there are many procedures that will be highly complex from infectious standpoint of view. What is changing at the moment is something we see on a daily basis and in our clinical practice. I practice in Switzerland, so it's a highly developed country, but even we have extreme challenges with rising resistance in uropathogens like E. coli. We see an increased rate of infections, hospital-acquired infections, catheter-associated infections that are harder and harder to treat. And when we're thinking about the future and more multi-resistant organisms, we will have longer hospital stays, which are associated with higher cost and an even higher risk of infection. And we will have higher surgical failure rates, because if we think about the complications arising from post-operative infections like strictures at the ureteroileal anastomosis, and this is something we will see more and more common. If we try to imagine the unimaginable and think about what could be the worst implications following from this report, we have to have the global perspective in mind. Globally speaking, we have an unregulated antibiotic use, and on many continents, still poor sanitation, poor healthcare system, wars, famines, and. In Europe, especially the European Union, sets very strict regulations when it comes to antibiotic use in farming, in produce, and. But worldwide, that's not the case, especially in the underdeveloped countries, low-income countries. They have limited access, limited financial possibilities for diagnostics, stewardship interventions. So, if translating to factual changes in our healthcare system, we are running with open eyes into a collapse of our healthcare system. We will go more in the area of pre-antibiotics, common infections like urinary tract infections or pneumonia, which had the highest mortality of all infectious diseases in the pre-antibiotic area. More and more deaths, like already said multiple times, and high-risk medical procedures like transplant surgery, chemotherapy, major surgery in every specialty will become very, very dangerous for the patient. Small interventions that we do on a daily basis, few hundred times a year, prostate biopsies, C-sections, joint replacements could bear fatal complications for our patients. This means that urology will become a high-risk field of medicine. Every urinary tract infection will be very difficult to treat, will need intravenous parenteral therapy. We will have higher rates of sepsis requiring ICU treatment. Our major surgical interventions will become so dangerous that we will have to stop doing some of them, stop doing interventions to the risk of infections. And as already said a few slides ago, a return to pre-antibiotic medicine about 100 years after the first antibiotics entered our healthcare universe is more and more likely. Even minor infections will lead to very, very severe results for our patients. We will have high morbidity and mortality after all. Economically speaking, which is very important at the time, since all our healthcare systems are getting more and more expensive, this is a fact that will go on and even skyrocket. So if we have skyrocketing costs of healthcare systems and more deaths attributable to antimicrobial resistance, we will have a declining workforce, we will have a decline of global productivity, which will cost even more economically speaking, which could lead to something like antibiotic black markets, further fueling antibiotic resistance. And worst of all, social and regional inequality will grow. The gap between the northern and the southern hemisphere will increase most likely. Which procedures for us will be at risk if we're talking about increased risk of infection? Transrectal prostate biopsy. Nobody will be able to perform a procedure like this with such severe implications for a patient for minor diagnostic intervention. Prostate cancer detection will be under threat. Small benign surgeries for stones or benign prostatic obstruction will be very, very dangerous. And we most likely will have to discuss with the patients if it's even possible to perform these procedures. Major surgery, cancer surgery will decline because the risk for complications will increase. UTI management resistance will limit treatment options, and we will have many hospital stays and hospital admissions to treat our patients. Just discussing prostate biopsy because it's very close to my heart and it's something I'm very passionate about. I think very small intervention for us, but very easy to adapt to new approaches with less and less risk of infections, because at the moment in many countries, the transrectal approach is the standard. There is a shift in Europe. There is a shift in North America to a transperineal approach because it's a safe alternative, and many of us are performing it without antibiotics. But if we think about increased multi-resistant organisms, is it even safe to perform any intervention without antibiotic prophylaxis? If we're rethinking the UTI management, we will have less options. We need to think about more culture-based therapies. Just empirical therapy alone will or won't be enough. We should think about shorter antibiotic courses and non-antibiotic alternatives. We need to discuss rapid diagnostics, something as quick as PCR-based diagnostics, CRISPR-based diagnostics, or MALDI-TOF. At the moment, many of us are waiting 2-3 days for urine culture results before we can adjust our empirical therapy. These are interventions that are essential for antimicrobial stewardship strategies and are immediate conclusions from the O Neill report. What can and should urologists change? First and foremost, everybody should be very, very strict when it comes to prescribing antibiotics. Every antibiotic should have a clear indication, and we should aim for a clear result and stop prescribing antibiotics just to prevent any kind of intervention. Because first and foremost, antibiotic treat infectious complications and diseases, and not always prevent them. We should try and aim for delayed prescriptions for mild infections, mild urinary tract infections, localized cystitis. Go for a non-steroidal antirheumatic therapy. Go for increased fluid intake, and we should stop prescribing immediate antibiotics. We should heavily rely on local resistance data and personalized resistance data from the patient. But we also need changes, generally speaking, in industry, policy-wise. We need to address the matter. We need new antibiotics. We need new funding. There are many organizations that try to do this on a crowdfunded basis like CARB-X, but more and more effort is needed. So we are all more or less in the midst of this discussion, and I think we can promote antimicrobial stewardship in every workplace we live in and try to increase visibility for this topic. We need strong regulatory measures, for sure, not only in Europe, but on the European continent, on the Northern Hemisphere, and especially on the Southern Hemisphere. We need strong incentives for our colleagues from industry. To come to an end and conclude my talk, my final takeaways. We're steering into a direction where we will have millions of deaths each year attributable to antimicrobial resistance if we are not changing the way we practice medicine. We're facing an enormous economic crisis. And the overuse and extreme misuse of antibiotics in healthcare systems and agriculture will have dire consequences for everybody. So our path forward is to promote antimicrobial stewardship, because antimicrobial resistance will reshape our field, urology as a whole, surgically especially. Innovations are key, so from bench to bedside is very, very important. We need new diagnostic interventions, we need new antibiotics, we need new rapid point of care testing, and we need global cooperations in order to tackle antimicrobial resistance and stewardship. And in my eyes, everybody from our community, everybody in our field, should take action now. Everybody can start tomorrow. Reassess, is the way I'm treating urinary tract infections the correct way? Am I up to date on my guidelines? And. This concludes my talk. Thank you very much for your attention. I'm open to questions via email. I'm sorry that I could not attend the meeting in person, and thank you very much.
Well, thank you, Fabian, for a very thought-provoking presentation. I believe, Jenny, maybe you could comment on this question in the Q&A box about the role of the urologists in terms of development of guidelines. We are being asked about our relationship to the gynecologist. Can you comment on that briefly before you close the session?
Yes, absolutely. I'm happy to answer that question because I think it's quite important that not only urologists, we have contact to infectious diseases every day, but also gynecologists do see those patients and do treat those patients. And with our EAU guideline and all other national guidelines, we try to reach not only to urologists, but also to gynecologists, to GPs, to microbiologists, to everybody who's in charge of treating and diagnosing patients with urinary tract infections. So it's our goal to implement our guidelines to a broad spectrum of people who do take responsive actions for those patients. So it's absolutely necessary also to implement gynecologists. And yeah, considering the advanced time, I'd really like to warmly thank our speakers, Tommaso, Sören, and Fabian, for your lectures, which were very informative and well-structured. And I'm happy to give the closing remarks for today's very successful ESIU webinar. We have learned that antimicrobial resistance is a growing global crisis that demands urgent and coordinated action. And we have seen today that challenges are particularly severe in high-risk regions in India, Sri Lanka, Pakistan, and where those resistant rates are rising at an alarming pace. And addressing these issues requires a multidisciplinary international effort. And let's take those knowledge shared today and turn it into action. And I'd like to thank you again for your participation in this ESIU webinar. And Truls, I'd like to ask you if you would like to add some closing remarks.
No, I think what you just said was so beautiful, so I won't say anymore. Thank you.
Mm-hmm.
So then, enjoy your evening, and thanks again for your participation.
Mm-hmm.